Hi, I'm Andy Rosenkrantz, Editor-in-Chief of AJR, and I'm here today with Dr. Melissa Reichman, Assistant Professor of Radiology, and Dr. Katia Dodelzon, Associate Professor of Radiology, both at Weill Cornell Medical College. And they'll be discussing with us their recently published AJR article on bleeding events after breast biopsies. Thank you both for joining us here today.
It's a pleasure to be here, Andrew.
Thank you for having us.
To start us off, what is the key gap in the prior literature that prompted this study?
Thank you for that question, Andrew. Breast and axillary core needle biopsy is the standard of care for tissue diagnosis and is really the preferred method of obtaining results for any indeterminate lesion within the breast or the axilla. And in fact, more than 1 million women undergo image-guided core needle biopsy annually in the United States. And even though it is considered a very low-risk procedure, its most common complication is that of bleeding and hematoma formation. Currently, there are no breast-specific guidelines for management of patients on antithrombotic or anticoagulation therapy prior to core needle biopsy. And in fact, the American College of Radiology recommends that each physician and breast radiologist determines whether the potential discontinuation of antithrombotic therapy for a given patient undergoing core needle biopsy be done on a case-by-case basis. But one needs to remember too that there is a significant risk of also discontinuation of therapy. Obviously, these patients are on antithrombotic and anticoagulant therapy for a medical reason. And so a temporary discontinuation for a low-risk image-guided intervention carries with it also the possibility of other thromboembolic events that may be life-threatening. And so we really wanted to look at our data and see if the temporary discontinuation of antithrombotic therapy prior to core needle biopsy actually carries with it a diminished risk of bleeding, so that it could be justified in the setting of potential risks of pausing such therapy.
Turning now to the study at hand, you included patients from 2 different time periods. Can you tell us about those periods and how many patients were in each group?
Thank you for asking about that. I think our institution has the perfect model for doing this study. We looked at patients between January 1st, 2014 and December 31st, 2019. And within that time period, we did have 2 groups. We historically used to discontinue antithrombotics and hold these antithrombotics for 5 days prior to biopsy, delaying diagnosis and also risking thromboembolic events. The second time period that we looked at was when we, in 2017, decided that we no longer were going to discontinue antithrombotic therapy, but instead we're going to maintain antithrombotic therapy because the risk of any complication is extremely low. In other studies, it was less than 1%. So we did stop. We continued antithrombotic therapy throughout the biopsy. And so this was important to look at. And so the number of patients we had in each group, 4,665 patients not receiving antithrombotic therapy, 423 were temporarily discontinued antithrombotic therapy, and 214 maintained antithrombotic therapy. And we had in our paper a total of 637 patients on antithrombotic therapy, which is much more than has been looked at in previous studies. So I think it's important to note that we looked at these 2 periods where we were biopsying patients not on antithrombotic therapy, and then we were biopsying patients maintaining antithrombotic therapy throughout the course.
One endpoint was imaging apparent hematoma. How was that defined and what did it show?
Yeah. So we did, as you alluded to, looked at 3 different endpoints in our study, 2 of which were really patient-reported, such as a palpable finding signifying a palpable hematoma, and bruising, which would be visually apparent to the patient. But much more sensitive is the evaluation for imaging apparent hematoma, which we define as a new mass or a focal asymmetry at the site of biopsy on a post-biopsy mammogram that we obtain after the majority of our ultrasound-guided, MR-guided, and stereotactic-guided core needle biopsies. And we defined the presence of that hematoma or imaging apparent hematoma as measuring at least 1 centimeter, which is consistent with the lower limit of the size of post-biopsy hematomas detected by mammography and prior studies. And what we found was that there was no statistically significant difference in imaging apparent hematoma, as well as palpable hematomas on patients who were maintained on antithrombotic therapy versus those who temporarily discontinued or withheld antithrombotic therapy. So again, underscoring the safety of continuing antithrombotic therapy at the time of core needle biopsy for these patients.
So the patients were also routinely called and asked after biopsy about subsequent breast bruises. Can you comment on that part of the study and what it found?
Yeah, so these additional symptoms included, as Dr. Dodelzon had mentioned, a palpable hematoma where there was no statistically significant difference in those that were maintaining anticoagulation or discontinuing anticoagulation. Additionally, they were called and asked if they had a breast bruise or any breast findings or symptoms that they experienced following the biopsy. And with this, we did see that there was an increased percentage, 6% of patients maintaining antithrombotics had a breast bruise as compared to those who were not on anticoagulation or those who discontinued anticoagulation. So I would recommend from our study to tell patients the risk of breast bruise if they are maintaining antithrombotic therapy.
And then the EMR was reviewed for clinically significant hematoma. How is that defined and what did that turn up?
So most importantly, we did not find any clinically significant hematomas during our study period, showing that it is a very low risk of, these clinically significant events. And this was a clinically significant event is defined as someone who would need to go to the emergency room, have a surgical drainage or an interventional drainage or hospitalization for a bleeding event.
And finally, the study gave a multivariable analysis for predicting these various bleeding events. What was in the model and what did it find?
Yeah, so we, in the model, we wanted to control for variable factors that we investigated as potentially being associated with increased risk of bleeding, such as age, increasing age, biopsy imaging modality, MRI versus ultrasound, needle gauge, number of biopsy samples, and ultimate pathology results, so benign versus malignant. And we found that when controlling for all of these factors, again, discontinuation of continuation or maintenance of antithrombotic therapy during the time of breast and axillary core needle biopsy was not a significant independent predictor of both imaging or imaging apparent hematoma or palpable hematoma. But as Dr. Reichman mentioned, it did independently predict increased risk of having or developing a breast bruise. So that is something that we should counsel and educate our patients on.
So based on these findings, what do you recommend?
So based on the findings, we recommend continuing antithrombotic therapy at the time of core needle biopsy, both breast and axillary, as we looked at both, although more studies are certainly recommended or warranted rather to tease out the potentially more risk-associated bleeding within the axilla, which we did not find in the study, but a larger number certainly is warranted so that we can make more evidence-based recommendations. But based on what we saw, continuation of antithrombotic therapy at the time of core needle breast and axillary core needle biopsy should be considered and continued, and patients should be counseled on the potential risk of bruising. And this obviates, as Dr. Reichman alluded to, the delays in scheduling patients, the anxiety that's associated with waiting for biopsy while being off anticoagulation, and most importantly, the potential risks of thromboembolic events by withholding antithrombotic therapy.
Any key limitations to mention?
Well, every study has limitations. We, first of all, were a single center retrospective study. The risk factors for bleeding, including various comorbidities, were not evaluated. And I think most importantly, the palpable hematoma and breast bruises are subjective and sometimes not able to be recorded in the EMR or gotten as accurate history from the patient. And I think that is a limitation in studying, patient symptoms, clinical symptoms.
And any final takeaway for our listeners?
Well, so we showed that the frequency of imaging apparent hematoma, palpable hematoma, and breast bruise after core needle biopsy in the breast and axilla are low. And it's important that there was no statistically significant difference in patients who were maintaining antithrombotics versus those who discontinued antithrombotics. So I think it's important to see new guidelines or to have some type of standard protocol for any institution, private practice, to follow guidelines saying that we can maintain antithrombotic therapy. We don't have to delay diagnosis. We don't have to have that risk of thromboembolic events in these patients. And also, of course, to counsel patients regarding an increased risk of breast bruise if they are maintaining antithrombotic therapy.
Dr. Reichman, Dr. Dodelzon, I really appreciate your both coming here and sharing your insights with us.
Thank you so much for having us.